Welcome, everyone. My name is Nicole Del Castillo, or Dr. Del Castillo. I'm the director of the Office of Diversity, Equity, and Inclusion here at the Carver College of Medicine. Thank you for joining us today as we are having a lecture entitled Pursuing Health Equity, a Call to Action. Today, I am speaking to you from Iowa City. I would like to acknowledge the name of Indigenous people community and pay respects to their past, present, and future elders. Please read the University of Iowa Acknowledgement of Land and Sovereignty. February is Black History Month, where we take time to celebrate the achievements of Black Americans and honor the significant role and impact they have made in all facets of life and society through United States history. Dr. Carter Woodson chose February because Frederick Douglass and Abraham Lincoln, who he felt had greatly influenced the lives of African Americans, had birthdays in February. Since 1976, each American president has endorsed a specific theme for Black History Month. The Black History Month 2022 theme is Black Health and Wellness, focused on the importance of Black health and wellness, which is connected to our lecture today. Today, I have the pleasure of presenting our UI Healthcare Black History Month speaker, Dr. Lou Hart. Dr. Hart is the inaugural medical director of health equity for Yale New Haven Health Systems. His mission in Yale New Haven Health System Office of Health Equity is to eliminate unjust racial and social barriers that contribute to devastating health disparities for our patients. This goal is part of a collective effort to improve the health and well-being of all patients by proactively identifying and working to eliminate institutional bias, structural racism, and impediments to health. Dr. Hart envisions a system that is more just, resilient, data-informed, and accountable in providing high quality, safe, and equitable care to every patient, every time. By calling everyone into his collective mission and acknowledging that there is no comfort in growth, in the end, he believes that we are always stronger and better as we grow together. He's active clinically and continues to see patients as a pediatric hospitalist, where he's responsible for teaching medical students and resident physicians as an assistant professor of pediatrics and faculty member in the Yale School of Medicine. Prior to joining Yale while the director of Equity, Quality, and Safety at New York City Health and Hospitals, the nation's largest integrated public health system, he founded and led the Medical Racism Initiative that focuses on abolishing the use of race-based clinical tools and algorithms that further contribute to health inequalities. In New York City Health and Hospitals' initial efforts, they were successful in eliminating race-based adjustments in GFR reporting, VBAC counseling, and pediatric UTI risk assessment from their entire health system. Please submit any questions you have in the Q&A at the bottom of your screen or chat, and that will be viewed by the host, and we will answer those questions at the end of Dr. Hart's lecture. So now I will hand it over to Dr. Hart, who will give his lecture.
Excellent, and good afternoon, everyone. It's so lovely to be with you all today. It's a great privilege to be able to share this space with you all on this beautiful day here in our beautiful country, to really get into some, I hope, very thought-provoking, constructive dialogue. As said in my bio, I want to call us all into this space because it's going to take all of us to grow together so that we can get to the other side and we can accomplish our collective goal of ending human suffering for all. So I'm really excited to be here and to share some of the work that have been ongoing here at Yale, as well as my prior place of employment in New York City, but really just to share a perspective that we've had, and really excited to engage in this kind of constructive dialogue. Again, it's going to take all of us, so let's jump right in. In terms of disclosures, I do have one, it might be relevant financial disclosure. I work for the American Medical Association in a consultant role where I am paid as just reading the comments, where I'm paid as a faculty member of their peer network. I'm paid for my teaching and curricular design, but that really shouldn't involve any financial disclosure related to this talk, but just wanted to put that on the table. I do, however, like all humans, I have no financial bias, I believe, to this lecture. I do have my own personal biases, and that's just what I want all of us to start to understand. We all have our own personal biases. That's what makes us human, and they're based on our unique paths and experiences in life. We can't overcome what we don't acknowledge. So I think in me acknowledging and showing my humanity, my vulnerability, saying that I do have my own biases and I work on them every day, it's an evolution that all of us are in this pursuit. So let's please come together and create this brave and honest space where we can really have these difficult conversations and find growth in the opportunities that make us a little uncomfortable. Let's empathize, let's humanize, and let's really start to think about those systems and structures that are involved in this work, not individual blame or personal attention to be taken, but really starting to think about those hierarching institutional or systematic themes that might provide us opportunities for improvement. So some quick learning objectives. You'll see this slide come up numerous times during the talk. And it's really just the first you see here on the screen for those who are able to understand some of the historical roots of race in medicine, to identify some key structural inequities and how they contribute to healthcare disparities, to understand some of the unjust and disparate impacts that patients have when they receive different levels of care on equity, quality, and safety in patient care, and some system level strategies to overcome such powerful forces that have long been ingrained into the system, but that are we are perfectly in an opportune place to overcome together. Quickly, for those able to see on the screen, there's a picture of 5 faces. There's some text at the bottom, but I want you to think what comes into mind. When you look at this screen, what do you see? Do you see 5 different races? Or do you see one race, the human race? I'd like for us to jump into this a little bit more. The birth of racial categories as we know them really started, these aren't that old of a concept. In no point really in history of mankind have we been so prolific or explicit about creating racial groups as what came about during the 18th and 19th centuries, really during a period of European advancement, but also at the time of European imperialism, colonialism, as well as transatlantic slavery that was occurring. The idea of race science really began to flourish as a biological explanation for how human beings could be treated differently at the same time as were these ongoing kind of cultural evolutions about liberalism and all humans are created equal and all mankind have the right to liberty and the pursuit of happiness. Unfortunately, this was hard to palate for the masses, so thought leaders at the time thought it would be important to really use an objective, biologically accepted practice or understanding framework for why certain humans might be thought of as less and might be okay to subject them to the cruelties of these types of conquests and pursuits. So the idea of race science really began to flourish. And this was the idea that humans could be divided into these separate and distinct groups that were well related, created a hierarchical value of their social and their biological worth. The first 2 physicians really known, there are many more, but that are really known about in terms of writing down their thoughts in this field are Dr. Carl Linnaeus, who classified that Homo sapiens fell into 4 distinct groups. We see them on the screen here as Europaeus, Americanus, Asiaticus, and Afar. And Dr. Blumenbach actually in his thesis in 1795 really took this a step further, and by measuring skull sizes, and what he thought was the most beautiful skull came from the Caucasus Mountains, which would be modern day northern Georgia, southern Russia, and the Caucasus Mountains. He thought that represented the original and the most beautiful race, thus sitting at the top of the hierarchy, the Caucasian race. Interesting to note, this attempt to really objectify the idea or create objective standards for why certain groups were different was widely accepted because it gave politicians, it gave thought leaders a way to explain to their constituents how these things were okay, how this was the beneficent law of nature, and how through social Darwinism, we could actually start to, dictate why things are the way they are, and we can play an active role in understanding why some groups can be treated differently and not have the same values or not have the same opportunities as others. The unfortunate thing about this are numerous, but the odd thing about how these racial groups, which were just arbitrarily made, came into existence is that there were 5 racial groups that Dr. Blumenbach really describes. And he describes them as the kind of the American, which is the American Indian, the Asian, which he describes as a Mongoloid, the Black African American, which he describes as an Ethiopioid, a Native, he describes it as a Malay, which today would be a Native Hawaiian or Pacific Islander, and then Caucasian, which is a very racialized term because it implies biological race. We know it today as white. The ironic thing is, a German philosopher and medical doctor in the late 1700s created the 5 races that almost 250 years later, we still use today. These were arbitrarily man-made by measuring skulls, not every skull, not an exhaustive list, but by creating quasi-objective, which would now be regarded as pseudoscience, opportunistic ways to describe and distinguish races. That the findings of these philosophers and medical doctors at the time were accepted as fact, and we are still enslaved to these concepts of social race, which we now view today, but very much back then they viewed these as biological races. And the United States federal government and its US Census and the Office of Management and Budget still purport that these are the 5 races of mankind. So this led to the concept of biological racism, which was this very unscientific notion, but was espoused at the time that given these objective differences in skull measurements and other phenotypical categories, that there are meaningfully different biological variations and differences that absolutely do create this hierarchy of value. And this fundamental thought that has crept in and unfortunately still exists in some parts of healthcare today, whether we know it or not, and I'll explain a little bit how that came into existence, has led to some devastating consequences that we now see as racial and social health disparities today. Dr. Samuel George Morton was an American anthropologist, and he theorized in the mid-1800s that intelligence was linked to brain size. And through the scientific at the time, but now viewed as pseudoscientific concepts of craniometry and phrenology, he actually amassed the largest collection of skulls, quite morbid, skulls in the world. And he concluded that since white persons have larger skulls, they must be superior because they must represent the most superior intelligence. Obviously, if you have a bias and you want to support your argument, you might have the perverse incentive to cream skim which skulls you were measuring that would support your argument. That's why I consider this unscientific, because by no means could you remove that level of bias and truly say that you've objectively measured all skull sizes. The scary thing about this work is that it continued. Dr. Robert Knox, an American physician in the mid-1800s, getting towards the end of slavery as we know it in our country, really took this a step further and said, these are fundamental things. There's reasons why these dark-skinned races are just inferior to lighter-skinned races because they've always been at the bottom. And I think that's the diabolic master plan around using a political structure such as racism to imply biological concepts, because it reinforces itself. If you treat 2 different groups differently and you start to create a marketing campaign and a social political understanding, you start to produce the very same outcomes that you were out to find. So if you treat 2 different groups differently and very much advantage one and disadvantage another, and then years later note, wow, there are differences across these groups. It's very circular logic because you've created that difference through your social groupings. And those unfortunately social devastating consequences lead to biological outcomes. And thus you use those biological outcomes as further proof of why those social groupings needed to be biologically separate. It's circular logic and it's a fallacy, and it's a fallacy inherently. But that's the most insidious part about this, because society, unfortunately, has been conditioned to accept historically that these things were normal. And unfortunately, those levels of biological race, of scientific race, still unfortunately exist with us today. And we have to actively acknowledge them and really question them in a very contemporary way, understanding where they started and understanding what detriments they have today. Now that we have a little history about where these racial groups came from, because often people don't know what race is. What's the difference between race, ethnicity, culture? They are interrelated in some ways, but the idea of race, just to prove it, just so I hope I proved it, is a very socio-political construct. It was man-made. It was nothing inherently ingrained in biological science that has persisted. It was used as a means to an end for the time to satisfy a mass that was trying to understand how you could be Christian and treat all of God's children equally, but at the same time treat some differently. Now we're going to talk about some of those key structural and social drivers that have led to these healthcare inequities. And this was a point that I really wanted to hammer home again. And it's just the idea that racism predated the races. It's not like these racial groups existed and then racists came out and said, see, that's the difference. It's that there was this idea of imperialism, colonialism, slavery, that we then said, well, we need to justify our practices. So why don't we create a made up socio-political, in terms of it's a social system that is institutionalized and governs across multiple groups, to create this differential hierarchical value of humans. So this was made up as a means to an end. There are no known biological determinants of race. We've seen this in the Human Genome Project. In 2000, we saw for the first time with objective evidence that 99.99% of our DNA is the same, and that the bigger differences actually exist within those racial groups as we know them than across them. You know, evolutionary biology says that we all started from a common African ancestry, and around 50 to 100,000 years ago, small populations left, and they only took small percentages of that genetic variation that existed on Africa at the time with them to different various geographies. When we think about the amount of genetic diversity that exists in sub-Saharan Africa today, there are more genetically diverse populations living in that one part of the world than exist across the entire globe. So the idea that there could be one black race genetically is just not supported by evidence. But unfortunately, today we still believe that these racial groups are meaningful and that they actually dictate something. And I say that has a lot to do with our past and flawed understandings, historic notions that have been disproven by fact, but are now held as beliefs. They're almost religion. It's a belief without objective evidence to prove it. And that's a very scary thing when we think about where this has crept into: science, medicine, places where we espouse ourselves to the scientific method, yet these beliefs still persist. So if it's not biology that are driving these differences, what could it be? This is where it comes to the idea of what is now known as the social drivers of health. Some might have heard the term social determinants of health. I think it's a maybe more contemporary approach to describe them as drivers, not determinants, as the latter is rather fatalistic and deterministic. These are contributors and drivers, but they don't have to be that way. They are not immutable and biologically ingrained. These are things that we as society, all of us, preside over and allow to occur. Thus, they are within our control to change. So now that we have this understanding of race and racism, Kaiser Family Foundation puts up this chart that really describes the multiple various areas where patients' social experience, or really humans' social experience, drives health outcomes, whether that being positive health outcomes or detrimental ones. Things across economic stability, one's neighborhood, one's education, the food. These are the social contexts that we find ourselves in, and they undoubtedly contribute. We'll talk in a second about how your zip code is more likely to relate to your outcomes in healthcare than your genetic code. That should not be allowed to happen. It doesn't make any sense. And these are arbitrary numbers like zip codes. We're not even talking about geography and worlds. We're talking about arbitrary distinctions of politically drawn lines that have created haves and have-nots. And these levels of social drivers, environmental impacts, have led to the biological consequences that we know as differential outcomes or health disparities. And if a disparity is unjust, then it becomes an inequity, because equity is about justice and fairness. So if these differences don't have to occur, if they could be avoided, if they could be changed, then these unjust disparities equal inequities. And I would say very much things on this screen are socially within our control. These are not so ingrained that they cannot be changed. And yes, it's not going to happen overnight. We're talking about hundreds of years of precedent that got us to where we are now. If every system is perfectly designed to produce the outcomes that it does, then this is what our system was designed to do. And if we can change this system, we can absolutely change the outcomes. So if this is something we value in doing and not allowing these inequities across social groups to widen, then I think it's important we have to change the system, not just change the individual players, but actually change the rules to the game so that we can actually grow the pie. This isn't a redistribution of resources. This is an opportunity for us to, equity is about growing the pie so there's more to go around, and that a rising tide will lift all boats. It often lifts those who are most resilient and strong, but tend to be at the bottom of the totem pole. But the idea is this is going to make us all better because we're going to learn to be more resilient, more accountable, and more data informed together. So I tried to find some good historical charts of out there in Iowa City, and I've yet to make a trip, and Dr. Del Castillo has invited me up for some Big Ten football in the fall, so I will definitely take her and you all up on that. But I found some charts of us in New Haven, which is an old city, one of a founding cities in our country, being given where it was in its geography on the East Coast. But we see that, like I said before, your life expectancy is very determined by where you live. And as we described, where you live is very much determined of the opportunities that are around you. So we have a 10-year life expectancy. And I don't know if you can see on the screen, but right here in the middle of the two is where Yale University is. And our health system's a little bit further south. But Yale University, a couple hundred years old, has played a pivotal role in this city. But for some reason, this city has a stark life expectancy gap, one neighborhood apart. We see in Prospect Hill, the average life expectancy is 82, whereas in Dixwell, that average life expectancy is less than 72. So there's a greater than 10-year life expectancy gap. We're talking blocks away from each other. And now that we have an understanding that it's not biology, because yes, there are different racial groups that live in certain parts of the city, but it has some more to do with these social, they still call them determinants. I posit they are drivers. These social risks or social opportunities that are presented around us in our environments that are actually predicting these differences in outcomes. And it's that level of residential segregation, of concentrating lack of opportunity into certain zip codes and abundance of opportunities into other, that create these differences that we see in biological beings. These environmental or social causes lead to biological outcomes as we measure in life expectancy. It doesn't really make sense as a species to live 2 blocks away from each other and to literally have fundamental different experiences of life. But this is America, and we have to start to reckon with our past and how we got here. So here's an interesting take on this. Those same districts that we were describing a slide ago that have 10-year life expectancy gaps or differences relate a little bit to a historical approach. And this is what I tried to find for Iowa City, but was unable to find the appropriate curve given my lack of understanding of your beautiful city. But again, I do plan on getting out there soon enough. But the idea is that because of historical practice, like redlining, we actually were able to efficiently segregate certain populations. And many of you know this historical construct, though it still exists today in certain ways in which mortgages are actually still approved today, the racial disparities that exist across loan approvals today. But this was a federal program to assist in providing federally backed mortgages so people could afford homes. And planners took maps and based on how well they believed those environments to represent safety and prosperity, preferentially graded those communities onto who should receive a loan and who should not have that type of investment, who would not be able to own their home, but would have to either rent or not be able to afford bigger homes or additions to beautify their communities. And we can see here, the green area next to the red and yellow area are the areas that we clearly see almost 100 years later represent that 10-year life expectancy. So it's very interesting that residential segregation might be the largest contributor to health inequity in our country. And I'm not alone in this belief. Dr. David Williams, a sociologist out of Harvard University, describes housing segregation as probably the most pernicious part of racism in our country, as a system of public policies, like we see one here, and rigged lending practices channeled Black and often other minoritized groups into certain neighborhoods where no one else wanted to live. And this, unfortunately, is not unique to New Haven. This happened in every sizable city in our country. It has occurred for many decades, forcing most African Americans and other minoritized social groups to live in less desirable communities than white Americans. And I'm going to quote one of his quotes that literally sticks with me so it resonates so well with me. Even when they are living in the same city, Blacks and whites are living under very different environmental conditions. If you could eliminate residential segregation in America, you would completely erase Black-white differences in income, education, and unemployment, and reduce single motherhood by 2/3. All that is driven by the opportunities linked to geographic space. That is the power of racism. The most powerful mechanism is this one that no one sees. And that's exactly it. We hear about these things, but they're often on the other side of the train tracks or the other side of town where we really wouldn't find many of ourselves going. And it's just these inherent historical constructs that still have modern day consequences that allow these types of inequities to continue to flourish. If we all integrated every single zip code, we would be remiss to not see the suffering of our fellow human beings and say, wow, we really need to uproot this. This cannot go on. We should really change this. But when it's happening just out of our sight, it's a lot harder to acknowledge it. Besides seeing it on TV, it's a lot harder to empathize and humanize if it's not your great neighbor. But these are our neighbors. They just happen to be a couple more blocks away. So it's in our universal collective pursuit of ending human suffering that I call us all into this mission together of conquering health inequity and health disparities that do not need to exist. Let me give you some tools for how we're going to overcome them. I think COVID-19 really helped us unearth some of these inequities. What we thought were just health disparities, a concept that has been published in the literature for 30, 40 years, has not received the same type of attention as it has recently. And I think it was during the pandemic that we saw certain racial and social groups did so much worse than others. And we've disproved this concept that there was biological determinants that all of these groups had that certain other groups didn't have, especially made up, social race. But we consistently saw a theme that those who lived in certain social groups, like racial groups, ended up doing far worse. And our federal government began to recognize this through the CDC and saying that race and ethnicity were risk markers that played a proxy for other things. It wasn't the race itself, but these played proxies for who was more likely to live in concentrated poverty, in multi-generational crowded housing, to be uninsured and not have access to routine primary care, to be an essential worker and have to take mass transit every day, to live in food deserts that lack access to green spaces and healthy foods, to have more uncontrolled chronic disease and comorbidities. These were the causes. And how did these things get created? It's because of the social infrastructure that we had set up in our country that drove these types of outcomes. There was nothing inherent that these things had to happen, but because the society had set us up in such a way, these biological consequences were uncontrollable and we couldn't do anything about them. And we had nothing but to keep publishing more statistics showing that racial disparities very much exist and they very much relate to our past. And they are not biological. There's no way that measuring skull sizes meant anything. The Human Genome Project disproved that. So again, if these aren't biological, let's change them, y'all. So how did this levels of, this isn't new that we found it, but how did our impacts of unjust and disparate healthcare affect the equity, quality, and safety of our patients in our care? This was something that was very pivotal and received some controversy from the administration at the time when it was published by the Institute of Medicine. In 2003, the Institute of Medicine published this pivotal and seminal piece of Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. And it was very much the common thought that these differences are just relate to access and socioeconomic conditions, that it's just about poverty and access. Those are the reasons why racial minoritized folk don't have the same health outcomes. What this investigation found that even when you controlled for access and controlled in terms of made the adjustments for socioeconomic status, that minoritized, racial and ethnic minoritized populations actually had worse experiences of care and had worse quality of care received. So it used to just be they don't get in the door. But now the idea was not only when they get in the door, and we kind of try to stratify them for other individuals from non-minoritized racial groups who get in the door, they still get different levels of care, even once they get in the door. So this was the idea of, wow, like even if we just cured poverty, there would still be these differences. So what might this kind of show? This is the concept of unconscious bias or implicit bias that all of us have as humans. We see a lion run. This is part of our reptilian brain. These are the immediate judgments we make that help us in the long term evolutionarily survive. You feel hot fire, you withdraw your hand. You experience something. You're conditioned by the media to show certain individuals always looking like one way on TV. When you think about a certain role or profession, something comes to mind. That's a bias. Sometimes they're right. Oftentimes, they're gross overrepresentations of a stereotype that has been fed to all of us to continue to believe. And this is the most detrimental part about a system, a structure like this, is that it impacts healthcare. Like it impacts so many other areas, like we talked about, neighborhoods, education, finance, resources. But when it starts to affect human bodies, like what is more pivotal? What is more consequential than morbidity and mortality? And how many of you in your training even remember the days where we used to say, this is Mr. Johnson, a 58-year-old black male, like that was supposed to help us tailor our care to a certain patient. Often what that did was bias our care, introduce different differentials that are not biologically sound, and start to actually change the intent and the impact of the care we delivered. One step further, this introduced the concept of race-based medicine, of how we taught training physicians that certain racial groups needed different equations to measure their kidney function or their lung function, and how this absolutely contributed to bias, stereotyping, racially tailored practices. It limited our knowledge production because it said, oh, that's impossible. A person couldn't have that. They're not from that race. And it absolutely contributed to inequitable outcomes. Let's talk about race-based medicine for a second. In 2022, really in 2020, this got a lot of national spotlight. And unfortunately, we're 2 years later, and many institutions have still struggled with what to take as next steps. As many of you know, the National Kidney Foundation and the American Society of Nephrology has taken an active stance to improve their equation that they recommend to measure estimated glomerular filtration rate, or EGFR, which is a marker of kidney, how well a kidney is filtering a product, a muscle breakdown product known as creatinine. And 2 years later, I guess a year and a half later, they finally came up with an equation that was race-free. But the current equation actually says that Black patients should have anywhere from 16 to 21% different kidney function, and thus an equation should normalize for that difference. So if a Black patient's kidneys look sick, it's not that they're sick, it's normal for them to be that sick. And we should just increase the equation to make them look like they're on par with other groups. The bad thing is the equation literally said Black and non-Black. If that doesn't evoke Jim Crow South or separate but unequal, or separate, I guess, but at the time they thought it was equal, I don't know what else does. But the unintended consequence to a certain propagated biological cause that all Black bodies were fundamentally different than all non-Black bodies, this is a popular eugenicist view. And again, this literally contributed to inequities, not only at the patient care level, but in the ways in which academic rigor and discourse from training physicians all the way up to tenured professors viewed racial inequities. Oftentimes these were viewed as inherent, fundamental. There really wasn't much we could do about it besides study them. Now there's a new idea, a more contemporary approach. So a question for you all to consider: what equation do you all use out at the University of Iowa? And if you have adopted the new modern equation that is race-free, that was released in September of 2021, and you standardized that and communicated that to your providers and patients and gone through the clinical implications of making such a change, amen and kudos to you, because unfortunately very few health systems have taken these brave efforts to really prioritize this work in the middle of a global pandemic. But if you have, what other potential ways do race-based medicine creep in the way that you measure pulmonary function tests, in the way that you used to counsel vaginal births after C-section? These are equations that take into account race and provide different answers to the question. When all other characteristics are the same, they say race is the determining factor between what a normal reference range is, who needs a C-section, who needs to see a lung doctor, who needs to start a medication, there's information from the FDA in 2005 that said Crestor in Asian patients needed to be started at half the dose. And we're like, where did that come from? Well, in some of the studies, they showed that Asian patients were more likely to have a higher level of Crestor in their system, which is a very powerful statin to control lipids in the blood or fats in the blood. And the idea was, well, there must be an enzyme or there must be a genetic cause for this. And as opposed to using Asian as the race, why don't we just swab their cheeks? It is the 2000s, and actually do the genotype. And they found in a follow-up study that didn't happen until 2017, 12 years after the FDA's recommendation to start half the dose on Asian patients. They found that, interestingly enough, 40% of Asians that we enrolled in the study did not have that gene. So that means for 4 out of every 10 patients that were started on that medication, they were underdosed systematically only because they looked Asian. Yes, there was a genotype, but that's the whole point of race-based medicine. We shouldn't be using race as the risk factor. We should acknowledge racism and its social determinants or drivers, but we should also look into the genotypes that are responsible for some of these differences. There are genes that do change things, but races are not a good proxy for that. We should blind ourselves to the race when it comes to genetics and just look for those genes, because if 40% of Asians had that means those genes exist across other populations. because there is one race, the human race. So that means there are white patients, Black patients, Native patients who are actually being harmed from this race-based indication. It's a lazy crutch. It doesn't force us to do the deeper work of finding what is actually happening here. What is the cause? We just end up being lazy and resting on the idea that race is the risk factor. This is an ecological fallacy, one that we have to change. A classic example is you have two social groups. One group carries a lighter in their pocket and one group doesn't. And investigators say, wow, interesting. The groups that carry a lighter in their pocket have really bad outcomes when it comes to lung cancer. Lighters must cause lung cancer. And other investigators go, yeah, that's absolutely. We should spend lots of healthcare dollars and resources to really ban lighters and really screen for lighters. Lighters are the risk factor. And then one investigator says, might it not be lighters that are the cause? Might it be the fact that those who carry lighters in their pocket also carry cigarettes in their pocket? And might it be that those who carry lighters and cigarettes might light those cigarettes with the lighter and might inhale carcinogens, and that's the cause of lung cancer? And the rest of the research community goes, wow, we really dropped the ball here. And this is the idea. We cannot use race as the risk factor because it's lazy. It doesn't allow the investigative pursuit to find what those actual causes are. So I challenge you all to think about ways in which race tailors your practice, how race is brought up when considering differential diagnoses, when considering what medications to start on for a patient battling hypertension, when you're thinking about who to work up in the ED for kidney stone. There are many race-based algorithms and equations out there that are published, but there are often these more insidious practices that we all have based on historical, now proven flawed notions that there is such thing as racial biology. Finally, what are some system level strategies we can do to overcome this? I've been saying a lot of things, but what can we do about it? This is probably the most important part. And thank you for staying with me here. So I think we have to, acknowledge that very clearly and very explicitly that something is wrong. And that when we see racial inequities across social lines, that we need to be very clear and explicit about this. But without demonstrable action, words are cheap. That is not enough. This is just the start. Action has to be necessary, and it starts with leadership. I noted here that some of our colleagues up in Minnesota, just north of you all, have signed on to this pledge, as have, if there's one thing I know about the Big Ten, is that you can't let Michigan or Ohio State win. And both of those institutions also have signed on to this pledge around around the healthcare anchor network and the mission of local place-based investing, about declaring racism a public health crisis, not just in taking the words, but actually changing the way we spend our dollars for local place-based hiring and place-based investment. These are opportunities for your large health system to play a pivotal role in your beautiful city to ensure that all of its residents are benefiting from the prowess and from the amazing opportunities and resources that your institution has. And this type of thing starts with a health equity team. It starts with building a team of grassroots champions and senior leaders who have a vested stake in making this change happen, and starting your own committee, starting your own group, joining a national collaborative. This is the start. By no means the end, but this is the start, because it starts to alert people that these things are ongoing, and it gives people a little bit of a framework from which we've signed on to this. We now need to allow this work to flourish. We can't just check a box here. We actually have to fulfill our commitments to our own staff, to our own patients, and to the greater good of our nation. So again, moral of the story, don't let Minnesota, Michigan, or Ohio State beat us. These are some of the opportunities that we've taken as a quality and safety approach. Some people, when they hear the word racial injustice or they hear the word, reparation, these are very politically loaded terms now. And we did not want to have to turn half of our staff or a certain percentage of our audience off. So we said, let's talk about quality and safety. Let's use that as the framework for which we all understand. High quality care, very safe care, every patient deserves, every patient, every time. So if we can not have to have the controversial conversations about racism, though they are necessary, we also understand that we have to tailor some of our conversation to the audience. So for those who might potentially be still earlier in their journey, because we're all in a journey, myself included, but those who are earlier in their journey of understanding, it's important that they at least get the framework, that this is a quality and safety pursuit. And that type of framework is really incontrovertible. There's not really much you can say why we shouldn't improve the quality or the safety of care for all of our patients. So, these are some of the top social identities or patient health equity identifiers in terms of social demographic groupings that often are the place that you can apply an equity lens and find a disparity, and if it's an unjust disparity, an inequity in your health care or the health outcomes of your patients. And most people often say, oh, our data isn't reliable, it's poorly collected, it's really bad. I would challenge you to say the ones that are collected here are pretty decent. I'll give you that race ethnicity might have large groups of other, but if you look at the groups that you do collect, I bet that they're more likely representative of your population than not. I bet that, that it seems to be 20% is the number around the country on average is of this unknown or other. But okay, there's an opportunity for improvement. Who wants a QI project with a low bar? Easy to improve when you have such an opportunity right there. But the idea also is that, like, probably for the majority of your patients, if you use Epic or you have an EMR that allows quick reports, slicer dicer, you can see how many patients do not have a language collected. I bet you less than 5% of patients don't have a language documented in their chart. It's something we're pretty decent at doing. As well as health systems that are oftentimes, whether they're not for profit or not, they still like to make money. And they do a pretty decent job of collecting health insurance information about what level of coverage. So we're pretty decent universally at getting language because we need to have a conversation with our patients. We need to know how they're going to pay us. So Medicaid, Medicare, private insurance, these are some ways that you can start to frame your dashboards or your equity lenses so you can start these investigations. And then zip code. We just talk about how racial segregation and residential segregation across racial groups absolutely contributes to outcomes. So I bet most of your patients, even the undomiciled patients who are currently experiencing homelessness, still have a local shelter that they're affiliated with. So our zip code information is pretty robust. So I would say consider at least starting with language, zip code, and health insurance as three very ways that you have very good information on. The ultimate goal will be to go through all of this list right here and find ways that we can't. But as we're starting, we need to improve the data collection, at least of real race, ethnicity, ancestry, language. But we have pretty good language, zip code, and insurance information. We can start there, learn those habits about stratifying data and doing quality improvement across a lens like that as we continue to improve our data collection so that we can be in a place where when we do notice an inequity or disparity across a group, we will at least have gone through the process. It'll be part of our culture that this is what we do here at Iowa Health, and this is how we're going to build a team to start to get to the root cause. In your pursuit of collecting patient information, this is an old study. This is 17 years old. But the point still resonates, is how we frame it, how we ask our patients really matters. And this was a cross-sectional survey of internal medicine patients. And it just asked a very simple question. The first question, is it important for hospitals and clinics to collect information about race and ethnicity? What do you say? And you see kind of mixed messaging. Some people strongly agree, and there's different across racial groups. Some people say, no, I actually don't believe so at all. I really disagree that we should. And you see on the far right kind of what the average of total of all the groups combined believe. Yes, most people still think it's important, but there's a 20% that really don't believe that we should do this. If you ask that same question, but frame it in the way, is it important for hospitals and clinics to conduct studies to make sure all of our patients get the same high quality care, regardless of their social identity? What do you say? And you see the same question asked to the same patients is answered so differently. And it just proves it's all about framing. It's not that our patients don't want to give it to us. They just need to understand why, how their confidentiality and privacy will be respected, and what you're trying to do with this information. I think it's pretty understandable when you say we want to make sure everybody's benefiting from our care. That's why we do this. You see how high the rate of let's do it goes. We're talking 95+% of patients strongly agree that we should do this. So it's all about framing. And that's probably the most important lesson I can teach you all about this type of collection effort. It's how you frame it and how you market it to your staff, and more importantly, to your patients, because the gold standard is that patients will report this either through a portal, MyChart if you use Epic, through a census-style mailer, or through their classic registration workflow. But maybe y'all have kiosks that they can answer this information themselves. But you really want them to know why you're asking, why you care about getting to know them better, and what you're going to do with it when it does. And this study, 17 years ago, just shows we've had information on how to do this for a long time. Unfortunately, there's some lessons that we have yet to learn. The time is now. In terms of applying this equity lens into performance improvement, you have to start with that data collection. We talked about that. Then you need to create what are those areas that you're going to be looking at. I would say look at the things you're already looking at. Do you spend time looking at readmissions, at ED utilization, at breastfeeding, at hospital-acquired conditions? You name the quality indicator that you're already spending resources and effort to do, and apply the filter on top of that. That's the start. Second stage will be when you notice disparities exist, or you look at national data in the measurement or the management of hypertension or of cancer screening, where there are no national disparities that exist across racial or social lines, then you can do explicit equity-based projects. But at the start, you should just be doing it across some of your key metrics to see, are they even there? And then as you get in the habit of doing this and you create the data resources and awareness and a communication campaign and cultural change that supports this, then you can start to tackle those more explicit. We are prioritizing this group because they have been left behind. Maybe patients with sickle cell, or patients with HIV, patients battling mental health like substance abuse disorder. These are things that happen to all racial ethnic groups. That's why this work isn't just about helping Black Americans. The things that we learned by helping Black Americans, a historically very resilient and strong population, but one that has often been disadvantaged historically. And some of those historical disadvantages have been inherited over the generations. The things that we learned from helping that group are going to help us be a better system for all groups. That's the exciting thing about health equity. It's going to make us all better off in the end. Here is an example just of some dashboards that just highlight, but these are the kind of things I want y'all to be thinking about, ways in which you can start to visualize this, put that at the top of dashboards, put it on scorecard reports, and really start to build some of these kind of accessible, registries and run charts that people can see things over time and measure their efforts, just like a quality improvement project. I think the exciting thing about helping the most historically, again, strong and resilient, who often sometimes happen to be some who are the most disadvantaged. You think of those first generation immigrants who worked so hard to get to this country and to provide a living for their family members. So many of us on this call we are all, as Americans, and even the Native Americans of us, are descendants of immigrants. At some point, they immigrated to this country, whether this country was known at the time, depending when they came. And they all worked much harder probably than we work today. Not to say we all don't work hard, but that's kind of how it worked. We all came from this. So think of one example about an implementation that was brought into effect to help historically, let's say, a historically forgotten population. This is in the disability community. So in the 1960s, there really began this push to have something called the cut curb effect, where we actually started, cutting the sidewalks so that someone who is potentially in a wheelchair, who had different motor abilities, would have an easier time getting off and on the sidewalk. And it really wasn't until the 90s that the American with Disabilities Act really said that this is by federal law, we have to have this across all sidewalks, to some extent, so that all humans, all Americans could benefit from this public service, this public good that is sidewalks. So what started off as an implementation to help a very small disadvantaged group has helped countless others. Think of all of the older men and women who might have canes who also benefit that. They weren't the ones who were originally envisioned, but they benefit. Think of the mothers and fathers who are pushing strollers as they're trying to transfer between Zoom calls. They benefit. Think of the busy FedEx delivery man or woman who is, or person who is, trying to deliver packages. We all love Amazon. We're all trying to get our packages the same day delivery. They're able to do that because they can get off and on sidewalks much easier and push their packages. So what started helping one group led to productivity and efficiency that was beyond the initial scope. That's why health equity is important, because we're all going to get better. I just can't share that point enough. Not going to start too much with this slide, because here are just some examples of a numerous amount that we are considering here at Yale New Haven Health, and start to prioritize in terms of what we call health equity indicators. Some are calling them metrics, measurements, KPIs, key performance indicators. We thought those were a little cold, so we wanted to come up with something new, health equity indicator. Don't get lost in the nomenclature. The idea is that these are lenses or measurements, either process or outcome based, that you can start to apply stratification across to identify. But again, I talked about do the things that you're already looking at: access, transitions, then outcomes, then community spend. But just make sure, hey, are patients in Iowa City who have Medicaid as at the city and state level getting into our health system? Do we serve a representative population of what our city and state look like by race, by ethnicity, by language? If we seem to be cream skimming some patients out, then they're not even getting in the door. And then once they're in the door, are we referring some patients to the cardiology service and some patients are just getting taken care of by general medicine? Or some patients getting seen by subspecialty on follow-up in pediatrics and some just getting seen by primary care doctors? That's a transitions concern. Then we can start to think about outcomes. Everyone want to go right to outcomes when we haven't even done the first two steps about access and transitions. And then ultimately, when we start to get robust data and have really good understandings of these outcomes, we can then start to go upstream and think about those social identifiers, the community-based elements, and how our spend in the community can start to mitigate some of those things. We all have to spend monies to be able to keep our not-for-profit tax status through charitable spending, through health fairs. We are required to do community health needs assessments every 3 years by the federal government, the IRS, to keep these types of tax advantages. I know you are all as a public institution. So it's important that this is actually prioritized and we're not just spending dollars, but we're measuring our impact in these communities. Treat it like quality improvement. Here, just in a couple last slides, just talking about another way to ingrain equity And this is into the concept of incident reporting. And this really speaks to patient safety as a strategy for this work. And we all know that we need to create physically safe places that are not causing physical harm. And that's where most people understand patient safety. Let's not do a wrong site surgery. Let's not give them a wrong medication. Let's not give them sepsis through getting bacteria in their PICC line. But it has to be more than just that. We need to create emotionally safe places. We need to create places that have that are free of psychological harm, that people are happy to work, that they're motivated to do their best job. They're motivated to wash in, wash out. They're 200% accountable to their patients and to each other. That has to be a part of patient safety as well. The new push is really to even have this health justice lens, that bias, inequity, injustice are absolutely patient harms, whether we see them or not. So let's start to measure them, to show those who might not classically see them in their day-to-day, that patients might have these types of things, and these potential sources of bias or structural inequities might actually have contributed to that adverse event. So I would say we use RL Datix. Think about implementing it into your patient safety or incident reporting. And if you're not ready to do that, start at the department level and create an easy QR code that can go to an online survey that you can give to patients, and take a couple of residents or some junior faculty who might have some time. Not that any of us have all the free time in the world, but these are ways, at least at the departmental level, you can start to share stories of how patients are experiencing your care and whether they believe that bias or discrimination contributed to the quality and safety of their care. On a more local unit-based level, by the more feedback we can get from our patients, the better we're going to be, because we're going to be able to learn from them and not just paternalistically, maternalistically think we know what's going on. But sharing things like health literacy, language, disrespect, mistrust, cultural differences, these are the types of ways that we are going to learn more about our patients so that we can be more resilient and tell the right narratives. You have the data and the stories, wow, you're going to lead some cathartic change. These are ways that we're ingraining it into our root cause analysis system, and we're ingraining it again across a patient safety lens, which no one is really arguing at us about. If we said we're here to do anti-racism, there are plenty of my colleagues who'd be like, oh, come on, we're so busy, we can't do that, or Louis, that's so controversial, we're not trying to be political. And I would say, well, I'm not trying to be political either, but let's call it patient safety. I'm concerned about the safety of all of our patients, and I found a group that tends to be doing worse than the median when it comes to this type of outcome. Can we use a system to investigate what might be the cause? Very few senior leaders are going to say, no, we can't do that. Everybody respects safety and quality. And these are the different ways that you can look at it. Take a proactive approach through your root cause analysis is a retroactive approach. But if you think about proactively looking for it in this retroactive approach, those lessons that you learn can be proactively applied to make policy and systematic change that ensures that this doesn't happen again. And I say don't focus on the interpersonal and the human behavioral level, but really think more about the institutional level and the structural level, these bigger changes. Trying to change one apple at a time as opposed to just changing the whole tree, or even better, changing the whole farm, is much different. And if you're going to try to win every heart and mind is important and should be done as well. But at the same time, we should also be trying to change the conditions or the system that this work is happening in. If you can change every heart and mind over time, and you can change the rules of the game in terms of how we understand this, how our processes and policies to hold ourselves accountable transparently, you'll notice a lot more change tends to happen. And just having these conversations during your patient safety meetings are important, because more people will learn over time and it'll just become a part of your brand. They'll begin to market it and saying, look how good we are at rooting this type of stuff out. We are leading the nation and having these, what were thought to be difficult conversations. This is just part of what we do here in patient safety. So concrete next steps. Everyone, I've summarized some, but what are you going to do? How are you going to include equity as the first step on your leadership or departmental scorecards? What could you do? What is it that you measure in your department that you think is important? Whether that's around hiring, whether that's around managed care, whether that's around which insurance companies that you take and what the demographics of their beneficiaries look like. Whether this looks at, are you taking care of a representative population in your service line? You run a bariatric service? Are you taking care of the average American who is represented in certain social groups? Or are there only certain Americans that are benefiting from your program? Access, transitions, outcomes, community. Think about those. One thing you could do, and I explained some of them here, collect better data, start to stratify by zip code, by language, by race, ethnicity, if you have that, or by insurance type. These are easy ways that you can start. Do performance improvement with that lens. Think about what your health equity indicators are. We talked about the other two. Think about, this is next level stuff, but think about what a health equity clinical consult team could look like. We all kind of think about bioethics team, but think about creating a brain trust of individuals across departments who might be that health equity leader who could provide some semblance of leadership at the department levels, but could also, if a case comes up and someone, and you're a clinician at the bedside, or you're hearing about this in a patient safety review, you know exactly, there's a well-socialized list of, these are some of the identified leads that might be able to, and not just one person, a team, so that that cognitive burden and overload doesn't just happen to one person, but that team is ever growing, and the junior faculty and residents and medical students are brought up, that social workers, nurses, physicians, advanced practice practitioners, advanced care practitioners are all included. Because again, it takes all of us, and we all play a very vital role on this team. Think about what you're doing with your health equity patient data. I would recommend that you have a team that is kind of dedicated to looking at it with this lens, and obviously you want everybody to do it, but until that happens, we have to be very explicit until it is just implicit, until it is just imply that, yeah, all of our analysts look for this stuff. You have to have someone who's kind of is leading in this space. And it's much easier to lead, but it's much easier to lead by doership than just telling people what to do. You have to do it yourselves. And then obviously quality and safety. I talked about, if you have a quality and safety department, think about incorporating equity into that. Think about formalizing that, calling yourself the equity quality and safety department or equity quality and safety team. These are things that are important. And if we're not ready to get to equity, well, we at least need to get to parity. We at least need to get to equality. But I think we will never get to equality or parity unless we start to acknowledge that patients are starting from different places, and we need to take equitable approaches to get them there. Finally, it starts with leadership. If you have existing relationships with senior leaders, with middle management, with earlier career management, these are very important individuals to have to grow that allyship. Routine reporting up to the top is very important because they set the tone, they set the culture, but it starts with grassroots activism. So all staff are critical in this mission, and it's really important for us to acknowledge that. Socializing broadly and constantly communicating is the message. It's almost like propagandizing this work. Like, you need to message it early and often. You need people to know that patient safety is priority for us, and equality is not equity. And we have history in this country, and it's important that the only way we're going to overcome this is if we start to have these conversations, that everybody deserves high quality care. And in the end, transparency drives accountability. We measure what we treasure, and we treasure what we measure. So it's extremely important that if you're not measuring something, then it speaks to the value proposition it plays. And once you do measure something, you tend to care more about it, and you tend to be more explicit about creating goals around the opportunities that are identified. So it's extremely important that we all have a role to play with this. Just like quality and safety is everybody's responsibility, equity is very much a pillar of quality and safety. So it's important that we all know we have a role to play, and that we're only going to get through this. We're only as strong as each other. And at the end of the day, it's going to take all of us. We learned in COVID about trusted partners. We need patients and leaders from every racial, ethnic, and income group to be allies in this work. It can't just be a certain minoritized group that is leading this, because that trusted voice to others in that social group who are maybe not minoritized, they're going to potentially pay more credence if it's someone from their own group that is saying, hey, y'all, we have to get on this. Can you imagine what that would look like if all people in all different positions started saying, or more people in more different positions started saying, hey, this is important that we do this, y'all. It's not just lip service. I'm committing my team to doing it. Those team members are going to follow suit, versus if it's just the Office of Health Equity or just the Office of DEI saying doing it. It's easier to compartmentalize that as opposed to if it's everybody's role and responsibility. So thank you so much. I hope I saved some opportunities for some questions, close to 10 minutes. I ran a little closer than I would have loved. But again, I thank you all so much for this amazing opportunity to share some of this work with you.
No worries. Thank you so much, Dr. Hart. And thank you for all those, or Dr. Hart, and thank you all for joining us today.